Tonight we're going to be talking, this is Lisa Bell, and Lisa works here at Active Marin, and she's been practicing for over 20 years. She's a bit of a knee guru. She herself tore her ACL. Actually, like you, Karen, she was moved to Aspen to work in Aspen as a young therapist after having worked in more neurologic setting. And
trying to leave.
Anyway, and then when she went to Aspen to go get this great job, then is when she tore her knee. And so that started her interest in knees, and went through ACL reconstruction and rehab, and has done a lot of work with adolescents, ACL rehab, and then actually helped with developing a preventative knee program for Kaiser in Petaluma. So anyway, so we're lucky to have Lisa here. And then we also have Manu here, and Manu is Kalia. And Manu and Lisa have worked together years in the past, and Manu's been a therapist for about 15 years, and he's also an Ayurvedic practitioner and herbalist. So they were going to bring together, Manu's also written a book called Build Better Knees, and his, which is electronic. It's
we have a sample.
Yeah,
we have it
and we have a sample out
on
here.
the computer. Yeah, if anyone wants to look at it later.
So that's great. So anyway, we thought it'd be a really interesting talk to different perspectives of how to build better knees. We also may be having a surgeon coming later who will give a couple comments on his perspective too. So anyway, I think Lisa's starting.
Yes. Okay. So first, I wanted to start off with a little anatomy lesson in here. So we have a model of our knee joint. This is a right knee. This is the front. This is the back. The bottom bone here is called the tibia. Down through here. The top is the femur, and that's the long bone which goes from your hip down. The side is the fibula. And then what you see attached, there are there's one newly discovered major ligament, 4 major ligaments in the knee, and that's on the inside here, the medial collateral, and that goes from the inside of the femur to the inside of the tibia. The lateral collateral, or LCL, which goes from the lateral condyle of the femur to the fibula. And then in the center, and actually kind of shown better from the back, are what are called the cruciates. They're the cruciates because they cross in the middle, and they're named by their attachment. So the anterior cruciate goes from the top back of the femur to the front of the tibia, crosses in. The PCL crosses like an X, the exact opposite way. It starts in the top of the front of the femur and then goes down in the back of the tibia. And these ligaments are typically going to be injured by something traumatic. And one of the most common, as we've heard, is the ACL. And that's because the ACL prevents this bone, the bottom bone, from shifting forward and from twisting. And so it's very common to injure it with skiers, soccer players, basketball players. But I've seen someone injure it just twisting their leg walking on ice. So all it takes is a quick force. It usually is something that's pretty traumatic. You'll feel or hear a pop, and then it doesn't so much, if the ACL is torn on its own, it doesn't so much give you pain, but it gives you instability. So then part of the issue with that later is if you have that instability, can you start to kind of wear things down in the knee more? Okay, so oftentimes it's fixed by surgery, not all the time, I'll tell you. I've had some patients that have gone on to, depending on their lifestyle, not have the surgery if they rehabbed well, and if they weren't someone who was going to, say, ski again or something like that. The ones on the sides also typically, the most common one that would be torn with the ACL is the medial collateral, and that's if the knee goes sideways. But typically those are traumatic injuries. Okay. The 2 blue cushions, they're not blue in your body, in the center here, are your meniscus. So the meniscus, they're considered 2. And as you can see, the femur comes down, and it comes down like 2 different knobs and meets the tibia, which is a concave surface. And then the meniscus sit between them to function as sort of a gasket and to help to increase the shock absorption in the surface area. So that's part of the big function of the knee joint, is it has one of the largest surface areas of the joints in our body, and one of the primary things it does is absorb shock. So it is one of the joints that tends to wear out, and it's something that people have a lot of problems with. When it does wear out, typically they talk about it being either a medial compartment arthritis or a lateral compartment. Oftentimes it's medial, and so that would be the inside. And that's because of the shape of that femur coming down like that and hitting kind of those two spaces where it meets the tibia. And if it starts to wear out on one side or the other, what you can see is that will change the alignment. Say it's worn out on the inside, then the knee can start to tip. So you can start to see people with their knee bowing out to the side, or you may see them bowing inside or just being unstable through there. Now, as soon as you do that and you tip this side to side, that will also change the line of pull of this. So here's the famous patellofemoral joint. The patella is your kneecap, and the kneecap is a floating bone. And what this is sitting in are two tendons. Your quadricep tendon, so the quadricep is a big muscle in the front of your thigh, comes down and inserts across the kneecap. And then down here below it, it's called the patellar tendon, and that inserts here. So I want to point out, tendons are different from ligaments. Ligaments are passive structures. They're there to hold the bones together. Tendons are attached to muscle, so they're designed to move. So the patellofemoral joint is a different type of joint in that what it's designed to do is create more torque or increase the effectiveness of this pulley system. So it's a pulley system formed by your quadricep muscle, the quadricep tendon, and the patellar tendon. And when you squat and bend, that quadricep has to generate a lot of force to be able to control your entire body weight as you go down, to lift your entire body weight as you come up. And then that kneecap, that patella, is actually, it actually has kind of a tilt on either side, and it rests in a groove. The femur has a sort of groove where the patella runs. Sometimes we used to kind of use an analogy of a train running in a track. So if you change that alignment of the knee, it's going to change that pull of that tendon, okay? And it's going to also change the way this train runs in the track here. So a few other things that are not shown on here are also the famous iliotibial band, which actually starts way up high at the hip and runs all the way down, and it crosses the knee on the outside. And that's a structure that's designed to give stability. But depending on the position, the flex or bend of your hip or your knee, it will change where it's located in terms of if it's in front of the knee joint or back of the knee joint, and how it provides that stability. But also, if you can see, if that's attaching down here to my fibula, if this is bowed out or twisted, then that will change the line of pull of that also. Yeah. So those are some of the major structures around the knee joint. What are also inside cushioning where the tendons are bursa. And so if you've heard of the term bursitis, that can be inflammation of the bursa. The bursa are designed to help to cushion. So in a quick nutshell, those are some of the basic mechanics of the knee joint. The knee joint is considered to be, quote, a hinge joint, but which you think of as something that just moves in two directions. That would be it bends, it flexes, or extends. But in fact, it does have some movement in multiple directions. Our body is designed beautifully. And so even a slight change in that movement can change the structure and change the line of pull of all those structures in there. One thing that people might not be aware about is that when our knee goes in those last few degrees of when we extend our knee, there's a small bit of motion, normal motion that should occur where this bone goes from a position where it's laterally and then comes medially. And that's called the screw-home mechanism. I didn't make that up there.
So the tibia is rotating medial.
The tibia is rotating. Yeah,
on full extension.
The tibia is rotating medially on full extension. And then this is going to change this is how the patellofemoral joint is going to lock in that knee to give you stability when you're extending, and then it kind of unlock to give you flexibility when you're moving. So a lot of times, one basic thing that we look at in physical therapy, I mentioned, is range of motion. And generally the knee should have, we measure it on the side 0 degrees, so it's fully extended. It should be able to straighten out, so if you were sitting and your leg was straight out in front of you, you should be able to straighten your knee so the back of your knee touches the floor, say, if you're sitting on the floor. And then it should bend to somewhere around, normal is considered somewhere around 130 or 140, which is about here. But generally, at least if it bends to somewhere around 120, 110, that's enough to get out of chairs, get off the toilet seat, different things like that. But obviously, you're going to need more bend to really squat down further. So some of the basic things are maintaining that range of motion. And if you have limited range going into that extension or straightening it out there, and you're missing that little twist, that true home mechanism, then that can really change how your patellofemoral joint is working, how your iliotibial band is working, the lineup of the meniscus in here, and even the tug on all the ligaments in the area. So maintaining range of motion is important. Another thing is that we're looking at, who was it that mentioned all the way up and down the line, feeling different things, is the influence of the foot and the hip. So one of the most common problems, I don't know if you can all see this, is if we go down and look at the foot, let's take a look at, if I'm standing, when I load my foot, when I take a step and walk, my arch will go down, and then as I come over it, it'll come back up. So our natural motion is that our arch goes up and down. Now when my arch goes down, does everyone see what's happening at my knee?
Mm-hmm.
It's rotating, right? So has anybody told that they have flat feet or they pronate? Yeah. Okay. So if you pronate, typically what's happening is that oftentimes the foot will evert, and you might already land in this position, and then that's changing this line of pull of that patellofemoral joint. It also means that when I'm landing on it, my center of gravity is on the inside of this knee, so that's a lot of stress to the inside of the knee. So one of the things we look at is the position of, this is the midfoot, or the middle of the foot, and then you want the flexibility in the back here. Because one reason you can get that pronation is if I go to step over this foot, and I can't, and my Achilles are tight, and I can't step over it, they might force me to roll inward. Because if I can't quite get over it this way, but if I turn it out, I can step over it. So then you have this whole chain of events that happens up. You're tight in the back, you start to evert the foot starts to pronate, the knee starts to bend inward, and then that changes the line of pull all the way up the hip. So some of the things we're going to look at if you come for physical therapy is that flexibility at your ankle, the midfoot control is what we call it, and then if we go on up to the hip joint, we're going to look at your hip rotation flexibility. So, as I always say to my patients, the neck bone is connected to the head bone. And so since the femur, the bottom of the femur is the top of the knee, the top of the femur is the bottom of the hip. So one of the important things that we look at is something called also the Q angle. And that is, actually let me get a, that is, if we take from the center of the knee to, on the front of your hip is a bone, a part of your pelvis called the ASIS, or anterior superior iliac spine. And then we go down to this piece of bone sticking out is called the tibial tubercle, and that's where that patellar tendon attaches. If we center, this is our measuring tool called a goniometer. I really have no idea where that came from, but everyone always loves that. You put that in the center of the patella, and then put this at the ASIS, and then we line this up at the tibial tubercle, and it shows a slight angle. And there's naturally a slight angle. In women, it's 18 degrees, so there's usually more of an angle, and then in men, it's usually about 13 degrees. So women tend to have wider hips for bearing children, and that tends to make us go inward a little bit more. So if you have an excessive Q angle, then that will let us know that there's a change in that line of pull, and that's something that we're going to look at. Is it coming from the femur because you can't turn the femur out? Is it coming from the foot because the foot is rolling inward? Or is it coming because maybe you have injured your knee previously and your knee is weak and just wants to go inward? So some of it can be from the passive limitation, some of it can be from the active, what's called proprioceptive limitations, where your body has forgotten how to balance that knee. So those are long. So we're going to do a little test. I'm going to get my stopwatch. One quick test to take a look at. One of the things that, as I mentioned, we're looking at is what's called proprioception. That's your body's ability to stabilize through any joint, actually. There's proprioceptors at your spine. One of the quickest things I like to do is look at single leg balance. What you're training when you train that balance is your nervous system. You're training your brain. And you can always train it. You can always train the brain. You can always improve something there. So you may have lost cartilage. I've seen it before. You may have a knee that's worn out. By x-ray it shows that it's tipped. But the reason that I see people that have, by x-ray, their knee looks terrible. It's completely worn out. It's tipped sideways. And they come in and they're not that bad. And then other people who come in and their knee joint looks great by x-ray, but they're having all kinds of problems, is that proprioceptive motor control, is what is your body using to stabilize that knee or that leg. So, yeah, I want to mention, the next thing I'm going to go over real quick are some common injuries. So I think I mentioned already some of the ligamentous injuries that can happen usually from trauma. The meniscus is also something. So this can get injured, the meniscus can get injured either from trauma, so something forcibly twisting the knee, oftentimes a plant and a pivot or a twist, but they also wear out. So you can have degenerative injuries, degenerative tears of the meniscus, where over time it's kind of been wearing out and it's thin, and then all it may take is just a quick step sideways and boom, you're down. But when it happens, usually it's quite painful. You'll get as a result some swelling. Yeah, it'll take you down. So at that point, when you're having that acute injury, really there's nothing to do but at that point rest it and try to get the swelling down. The best way is elevation. I know everybody wants to ice it and put compression and they say, but I'm up around it all day. You got to elevate it. And then when you're ready, you start to get back your range of motion. So range of motion is always the number one thing that you try to work back on after you've had some kind of injury. Couple of the more common injuries in terms of chronic problems are the iliotibial band, and we mentioned that where it happens with a lot of the downhill runners, the descending, and then the repetitive motion because of that zone of impingement. And then we get to the famous patellofemoral joint. So the patellofemoral joint, I've seen people with patellofemoral problems in all ages, from ages 9 all the way up to 80. And that is because of the importance of it to really stabilize our leg and allow us to use our quadricep. And it's something that we used to focus on isolating the quadricep muscle, and they used to say strengthen the quadricep muscle and strengthen the inside of the quadricep muscle to pull the train over on the track. But what newer studies are showing that's more effective, or that we want to change, is the track under the train. Because say if my leg is going inward because my foot is rolling in or my femur is rolling in, even if my quad is really strong and it's pulling that tibia or pulling that kneecap over, if I don't change the underlying track, then I'm kind of fighting a losing game because I'm always going inward. So a lot of what we focus on at the patellofemoral joint now is actually hip muscles and hip rotator to strengthen, and then intrinsic foot. So at your foot, that control of that arch. And that's something that you can improve upon with the patellofemoral joint. There are other different techniques used to work on that, but it's a very common injury because of that pulley system that happens. There can be a tilt one way or another. There can be you can have a structure where the kneecap's a little bit high or low, but those are some things that we look at individually with different people. So those are just a couple of things, yeah.
That meniscus issue that you were talking about, how just over time it just wears down, is that the bone on bone that people talk about?
Right.
That big shock?
Yes,
And you just fall to the
exactly.
ground?
Exactly.
So
And
that's the bone on bone, is that meniscus?
there's cartilage that covers the end of the bone. So there's a whole bunch of structures in that joint there. So when the end of the bone actually has cartilage that covers it, and that in itself is another layer. So, but yeah, both the meniscus and that cartilage are worn out when the doctor says it's bone on bone. But even with x-rays, early degenerative changes actually don't show up on x-ray. So the x-ray may look great. When they look at the x-ray, they're only seeing bone, but what they look at is the space between the two bones.
Can you ever just fix that on your own with therapy, or is that once it's bone on bone, is it put in that
Yeah,
cartilage?
you don't regain the cartilage.
Although I'll say, having worked with a lot of knees, I used to work with people who did knee bone on bone, and we'd go through a 6-week program, and one of the surgeons I used to work with was really hard. He was sort of the anti-surgeon surgeon, and some of these people would be really intense with their strengthening, and then they'd come back and they'd always want to get another x-ray because they felt so much better, and they say, no, your joint space is still the same. But, so just because you may have very little cartilage doesn't mean you have to be in pain and dysfunction.
Exactly.
So it doesn't mean you would need surgery always. You know, a lot of times there's so much you can do through.
Can you work on alignments of the bone?
Exactly.
rubbing type things?
Exactly, yeah.
That's where the
So this is a good lead into what Manu's going to talk about. Yeah, go ahead.
The patellofemoral syndrome, what are the symptoms of that?
So the symptoms oftentimes are they're pain with squatting, pain with descending stairs. You can have pain with just plain old sitting. It's called the movie sign. I can't sit through a movie because when your knee is flexed and it's resting against it, it kind of cuts off the blood flow there. You can have some clicking, catching, a feeling like you might almost buckle. So it's something that actually can mimic meniscus. So oftentimes when someone comes in with some of this history, we might have to differentiate the patellofemoral versus meniscus.
So classically, anterior knee pain, front knee pain, somebody's would be more indicative of patellofemoral stuff. However, anything around that outside border, having pain along that path could be considered patellofemoral. Patients sometimes report pain underneath the kneecap. I've even had patients complain of pain in the back of the knee. So the referral is coming to the back of the knee. So you have to but though the problem is here, whether some of the cartilage is getting worn out or the surrounding tissues that insert along the kneecap are so irritated because of repetitive movement or excessive load, and then things like, as Lisa was saying, with the squatting, like coming downstairs, or the movie core sign and all those things. Swelling, any of those things could be going. Okay. Yeah?
Are squats good or bad?
For patellofemoral pain?
For anything.
Depends how you do the squat.
Yes.
Yeah, there's nothing wrong with squatting. I mean, if you look at a good amount of the rest of the world where they use the bathroom squatting down, technically, if you did that every single day from the day you were born till the day you die, those people have good hip mobility, good ankle mobility. So there is an excessive load just on that knee. So we don't do that. We sit in chairs. I go to work, I sit in a chair. I drive, I sit in a chair. Give you a broader perspective when you're considering recovery and rehab, and when you're dealing with a lot of these injuries, or for prevention. So I was listening to the news. I'm sure you guys have heard about the Ebola virus going on in West Africa, and they were interviewing a physician, and they asked him, so the mortality rates are 60-90%, I believe that's what they were saying. So the interviewer asked the physician, so what do you think are the reasons for the people who are actually making it through, the ones that are surviving? So what's going on? Do you know the reasons? So the guy goes, he's like, well, there are various factors. One of the reasons might be how early they get care. So I get infected, I get care immediately, chance of recovery are going to be faster. Right? Second reason might be the person's innate constitution, their immunity. So everybody's different. So that you get infected, whether one person makes it or doesn't make it. Third reason might be the amount of virus you're infected by, the number of viruses that are infecting the individual, so the amount of exposure that's taking place. Fourth reason is secondary health issues that are going on. Person's a diabetic, they have cardiovascular disease. The system is compromised, the reserves are down, thus they are not able to handle that, another problem now, right? And the last reason, I said, well, it could be also environmental factors, person's age, they're elderly, they're young, right? And a few other reasons. So why did I tell you guys that story? Because it relates to even knee-related issues, if you think about it from that perspective. Because if I have a knee problem, if I break it down into all those factors, I can say, well, it could be how soon do I get in to get that care, as Lisa was saying. If I have the beginning stages, so some irritation problems going on, I get in and get it addressed, I might be able to possibly prevent excessive wear and tear. Then it might lead to problems later on. Right? So how early I get care for the problem. Second thing is the individual's constitution. So my physical, psychological, and physiological makeup is completely different than yours, than hers, and than everybody else's. Thus, my ability to handle certain sports, certain things, day-to-day activities is different. So when I have an injury, it also determines the ability to recover from problems that I have, which is different than hers. Okay, so you have to always consider that component also. Cindy was saying, why, the arthritic knees, and though they have bone on bone, but the person's moving around fine, they did some rehab, that part didn't change. But just the way their system responds, they don't have perception of pain, and they're able to function better than somebody else who has minor arthritic changes, but just has severe pain and they can't function properly. So those are the individual differences you have to consider. And then we look at the amount of wear and tear that's taking place at that joint. So the amount of activity. So for example, runners, right? 1, 2, and somebody else was running too back there. So if I have pain and the amount of load that's being placed on at that joint or the local soft tissues. So if I do repetitive loading at that tissue and it just is not able to handle it, it's going to start breaking down. Okay, that's just the way it is. So those are the things you want to consider and you want to look at. Then there are other factors too, which extends to, again, if I am a diabetic, how fast I heal is going to be affect also how fast I heal from that injury. Right? So look at all those things. My intent in bringing up that is so you want to get a better perspective on when you are designing your own rehab program where you're trying to recover from a problem or prevent injuries. Okay. A lot of times I see people are given exercises and they're like, go and do your exercises, do some quad work and come back. Well, the person isn't sleeping well, they're under a lot of stress. They're constantly in that go sympathetic mode. They can't heal, they can't recover. My exercises are not going to be as beneficial for that individual. We need to get a lot of the other components under control also in order to address those issues. Okay, so that's my spiel on that. All right. So now, in terms of injuries, so it's pretty simple actually, and 2 things you want to consider and look at. The first part is having a strong foundation. That's the way I want to look at it. And the second part is, foundation is having to do with me, so the subject. The second part is the amount of load, the overload principle. So we'll talk about the foundation and we'll break it down to 3 simple components. And this is where a little bit of the crossover is between what Lisa was already talking about. Mobility is the first component from the physical therapy standpoint. So as we said, Lisa was saying mobility at various joints, and she was showing you some of the biomechanics behind it, right? You want not too much mobility and not too little mobility. So not hypomobility, where you are not moving at a joint, it's too stiff, and not hypermobility or instability at a joint, right? So if my ankle joint is stiff, as Lisa was showing you guys, and my foot tends to turn out, and it's not necessarily true that you're going to get ankle problems. You might get knee problems, right? Usually the stiff joints are not the ones that give problems. It's the joints above that. So above or below the chain. So you must always treat above and below and look above and below, okay, if you truly want to. So those patellofemoral, you guys that were mentioned patellofemoral problems, so you have to look at that ankle as well as that hip too. If I'm missing that hip range of motion, it's going to be affecting my knee possibly too, okay? On the flip side, the hypermobility or unstable joint. So for example, if my hip is tight and I don't have enough extension in that hip, and when I walk, I'm constantly bent in this position, I have to hinge at my low back. So that low lumbar spine, I'm constantly doing this. So I'm hinging too much at that one segment because one of the parts isn't working properly. Your body's really smart. You'll find a way to move around things, right? So usually it's the hinge that moves too much is the one that breaks down, whether it's in the door or in my finger or wherever else. So when you guys are designing your programs and you're thinking about this for the knee issues, think about that ankle, think about the, even the foot, think about above the chain, the hip, pelvis, the spine, all the way. Okay, so that's when we think about mobility that way. The second part is strength. So there are a lot of components of strength. So you want to also consider speed, explosiveness. You want to consider the neuromuscular control, as Lisa was doing the test, being able to stand in one position and balance. Right. So when I'm designing a program, I want to consider all of those factors, not just for the athletes, but even for day-to-day activities. If I need to squat, I need to pick up things. Right. And think about strengthening not just local structures around here. You want to go down towards the foot, and as she mentioned, having that motor control of those foot muscles, or further up in the chain, hip and pelvic stability, core stability. So all those structures need to be looked at and strengthened when you're looking at those problems. Okay, so that's how. And there's a progression of things. So you might start out, where you're doing some non-weight bearing stuff, and Lisa was going to go into that more of that, and then you're going to progress towards more activities that are higher level activities, such as squatting, such as doing plyometrics and various things you can go towards. Okay. So the last piece of the puzzle is the health of the internal system. So the first two pieces are more specific. They're more having to do with physical therapy. So the last piece is you want to think about working at your nervous system, your hormonal system, and what I mean by that is the amount of stress you're dealing with, your diet, your lifestyle, various factors, sleep. So they will also affect your ability to recover from a lot of these injuries. Okay. They require a bit of time and digging in and figuring out, am I at my homeostasis, am I at my baseline, or I'm off, I'm not getting enough rest, and I'm exhausted, thus I can't recover from these injuries, and I'm dealing with these things. Okay. So questions? I move kind of fast. Go ahead.
I use the analogy often to patients of a lot of car analogies, saying if you're out of alignment, you're going to wear out. But I think what Manu is pointing out is we're not a car, we're living tissue, and that's something I always say to my knee replacement patients because they come in and going, how come it still hurts? I said, well, if you were a car, you replace the parts and go, but no, you've got living tissue. And so all of that has to recover. Just because they've replaced a joint doesn't mean that they've changed all the structures surrounding it. So they've given you an advantage, but it takes a long time to recover, right, from any kind of knee surgery. And so what Manu's pointing out is the downfall of some people say, oh, maybe try all these different exercises. But everybody's physiology is different, and that's what part of what makes you different from the next person. If you talk to someone else, oh, you've got any problem, and they say, try this, and you try it and say, well, it didn't work for me. Everybody's physiology is different. We're living tissue.
What about oils? Like, you hear about fish oils or certain oils that keep y'all lubed up inside. It's visual that'll just keep our machine running. Does that help?
Some of it does.
Do you recommend any over another? Or?
I mean, for example, omega-3 fatty acids and more animal-based fatty acids. Not, for example, flaxseed is not animal-based. So some of the other ones have shown to reduce inflammation or irritation.
Why do you think that is, given that the omegas are coming from the plants into the animals?
I don't know.
And that's why you've gone up the chain.
Yeah.
But effectively, it's from algae in the ocean. It's an interesting.
Yeah, it's just some of the studies have shown people tend to do better with the other ones. Not everybody, but some of them. And I have had patients who have taken just the omega-3 flaxseed or any of those other things.
Vegetables, yeah.
Yeah, and they have found better response with some of the other ones.
Interesting.
Yeah. So and it's the same with a lot of the other supplements too, the glucosamine and various things. 50% of the population I find they take it. Arthritic, for example, arthritic knees tend to do better with those, but there's X percentage that doesn't really respond that well to those. So.
How about turmeric?
The turmeric is great. Yeah. A lot of anti-inflammatory properties and a lot of that does really well actually. It's been used extensively in Eastern medicine for addressing a lot of those things.
What about topical like Tramiel or Arnica?
Arnica does really well. And there are various liniments in Chinese medicine that are used, or oil-based, alcohol-based, various ones that do quite well too. And they promote, the purpose of a lot of those is, I mean, the oil is being used, for example, as a delivery mechanism. Your skin is hydrophobic and lipophilic, so allows oils in. You're driving that herb deeper into that tissue. And some of those are warming oils usually because they're trying to promote circulation in that tissue. That's what they're aiming for.
Could you name one?
Sure. Well, Mahanarayan oil is one, I mean, I can give you the names if you like. Yeah, sure. Yeah, some are very effective. But even, for example, I've had patients use, for example, an inflamed knee, very hot, swollen, even rheumatic conditions. Castor oil is used because it's a bit cooling, anti-inflammatory properties. Same with coconut oil, is a bit more cooling, seems to help. Right? So, I mean, there's a host of things that can be used depending on.
You use the peppermint oil.
Oh, yeah, it's my new favorite. Peppermint oil is amazing, and this is actually really, I don't know what you think of peppermint oil, but it's, for pain, it's really good, and you don't even have to put it directly on your painful spot. You can just put 2 under your nose, and it's, there's been research on stopping the pain mechanism in your brain, so it kind of override the pain response, which is actually all in your brain, right? So it's, so yeah, I love peppermint oil. That's my favorite thing.
Yeah, I can tell you guys a little more when we get to the treatment part too.
The omegas, are they primarily reducing inflammation?
Into chronic inflammation, that's a different thing we're talking about. But most injuries in the initial stages, you want that inflammatory process to take place in order to facilitate the healing process, to make it move forward into the next stage. So, and there's a lot of, and then now there are a lot of studies too, and more I've seen physicians not prescribing a lot of anti-inflammatories. And I'm not even talking about the negative effects, for example, GI bleed and various other things that happen with that. I mean just the ability to heal. So for example, rotator cuff surgeries, after that, they're not giving anti-inflammatories because that tendon doesn't heal. So, and your body needs to go through that process to take place. So I think there are other things going on too with those.
Can you show us, like, a couple helpful stretches for knees, and then a couple not helpful stretches for knees?
Sure.
Just to give an idea.
Yep.
So sometimes I just see people, putting their legs up, and they're too low or too high, and I'm like, oh, God, they're gonna hurt their knees.
Yeah, sure, yeah. Well, as soon as we get to the treatment, we'll
Okay.
show. And do you have anything else? Any other questions before I? Okay, so one more point about the, we talked about the foundation thing, what you want to think about. The second important component is the principle of overload. And that's what you want to think about, the amount of load that you're placing on that tissue, right? So keep that in mind. So if it hurts and you continue walking on it or playing tennis or whatever you like to do, gardening, various things, and if it's giving you those signals, it's telling you something. Don't do it, don't do it. Right? So you must address the issues, otherwise you're going to continue to irritate that tissue. Okay.
She admitted to it, though.
Okay, all right, okay.
You're not listening to your mom?
Yeah. So did you want to move to the next part?
Sure.
All right, let's move to the treatment. I'll show you the stretches also.
Okay. So when we're talking about in terms of, I'm going to start with talking about an exercise-based treatment program, which is as a physical therapist what we're looking at. What I might do is prescribe those exercises depending on the stage of recovery that you're in. So if you're in a period where, you say, your iliotibial band is just acutely inflamed, you're walking in and you're limping, or your arthritis is just really bad and you're limping. So limping is my big sign. As soon as you walk in and you're limping, I know that I'm probably going to get you off your feet in something that's non-weight bearing. So non-weight bearing, where you might work on just bending the knee, is if you're on your stomach and you're bending the knee, and that's going to be an easy stretch of the quadricep muscle without cranking on that knee joint like this. And you might start by doing that. You do it on the stomach because the quad is a two-joint muscle. It crosses the knee and it crosses the hip. So you're going to do that on the stomach to get some flexibility and also to start to get the hamstrings working. I like that on the stomach too because you're bending and keeping the hip straight, and it simulates what your knee needs to do when you're walking. When we bend the knee when we're walking, we bend it behind us. We don't walk like this. We walk and then the knee comes up behind us. So you have to have this flexibility through the front of your leg there. So that's one example of a non-weight bearing. Or if I'm working on the quadricep muscle, one of my favorite things, so everybody can do this, and this is really easy, is just go ahead and stretch your leg out in front of you and rest your hand on your thigh and go ahead and prop your heel up, and we're going to do a quad set. And I want you to, quad set is where a set means it's an isometric. An isometric is where you just tense the muscle but there's no motion. So what you're going to do, so go ahead and put your heel down though. So when your heel's down and you're not moving, when you tighten that muscle, look down at your kneecap. Did you see your kneecap move? Everyone see that move? And then relax your muscle there. So a lot of times what happens is when you're in a lot of pain, I'll see people do this. Their leg is out and they go like this. Oh, I'm straightening my knee. Now, I didn't do anything at my quad. What I'm actually doing is using my hamstrings and pressing down. So a lot of times what I'll have to do is tell you to look at that muscle, put your hand on it, tighten it, watch that kneecap move, and you can even watch and see does it move straight. And the more you kind of give yourself feedback with your hand on that muscle, as you're holding it, try to tighten a little bit more extra. And did you feel it tighten a little bit more? And then relax again. When you give yourself that feedback by looking at it, feeling it, it gets your body in tune with that's what you're trying to work on. So a lot of times that simple quad set is done incorrectly. People go home and they'll be watching TV going, I did 100 of my quad sets. Like, really? Well, show me. and then they're doing this. And that's a simple non-weight bearing exercise that starts to help to get that kneecap moving, starts to get that quad turned on. I talk about it as like jump starting your car, turning that on, because that's one of the first things with, like almost universally with any kind of knee injury, that whole extensor mechanism shuts down. Then if that quad's not working and that kneecap isn't placed in the right place and you don't have stability, then you walk and you feel like it's going to buckle, right? Has anyone ever had that feeling? Yeah. Terrible feeling, right? And so getting that quad working and sitting, or just sitting with your leg out in front of you might be the first one I start with. Now I'm going to move that to weight bearing. So in weight bearing, I'm going to have you stand and straighten that knee. So this is something where we start to do that.
And I think that's important for picking up objects off the floor. Because if I can't bend at my knee, I'm going to start bending at my hip or at my back to pick up things off the floor. And then what goes next?
So people with bad knees end up with bad back.
Yeah.
Sacrum.
Say again?
Sacrum.
Sacrum could go too. Yes, that could go too.
The first one you did.
And so now when we're standing, here's the trick is that, so this is something where we start to do that.
And I think that's important for picking up objects off the floor. Because if I can't bend at my knee, I'm going to start bending at my hip or at my back to pick up things off the floor. And then what goes next?
So people with bad knees end up with bad back.
Yeah.
Sacrum.
Say again?
Sacrum.
Sacrum could go too. Yes, that could go too.
The first one you did, the importance of the heel on the floor is to close a chain?
Yes, exactly. Yeah. To close the chain and so that you're isolating that quad, and I'm just working on it without having to hold up the weight of the lower leg there. So we need to work on that. So this is just kind of an example of a progression in use. Okay. So from there, what I might go through, if we're looking at non-weight bearing, weight bearing, I'll just mention low impact cardio in terms of the fact that since again the knee is the greatest shock absorber, that one of the keys to recovery is not abusing that knee. So if you are a runner, you might have to actually take a break from it. And so you're going to go do a stationary bike, you're going to do some swimming, but you can run in the water. That's another great thing. And actually, even without running in the water, you don't even have to swim. Walking in the water is one of the first things I love anybody to do. Yeah, go ahead.
So did you just say that stationary bike is really good?
The stationary bike is good, yes. So yes, the stationary bike is good because what you're doing is you're taking away, when we walk, it's going to be actually even less impact than walking. Because when I walk, at some point, I'm on one leg. I'm 100% weight on one leg. When I'm on a stationary bike, my bottom's on something, both feet are on something. I'm never going to be with 100% weight on one leg. And then the repetitive motion it actually helps your cartilage. It helps to stimulate that cartilage. And a lot of people with knee arthritis find a lot of relief from doing that. Now initially if you start it and you find some sticky spots where you go, ooh, it's kind of stiff, I can't get through it, don't be afraid of it. You can work through it, and that's probably where you need to get that range of motion. And once you start going, that's a great kind of maintenance thing to do the bicycle, to keep that range of motion and keep that cartilage working.
But
So
be
what's a
careful
good
if you have
RPM?
Oh, yeah.
Sorry. No,
Oh, sorry.
just be careful if you have IT bend issues or patellofemoral issues. Sometimes you're getting on the bike, they don't like that because the kneecap, the repetitive motion can irritate that. So you have to be cautious. You might have to adjust the seat height and you have to play around with things. Maybe a recumbent bike as opposed to one of these. So
Right,
you might have
right.
to try out different things.
So this is also where the water is great.
Yeah.
I love the water. You can do bicycling in the water, you can sit on a step, or you can sit on a noodle and do some bicycling and walking in the water too. So those are ways to do some kind of lower impact and still get your heart rate going. So we're also talking about getting in a little cardio, not only for anyone that's athletic and you don't want to lose your conditioning, but for everybody else, cardiovascular exercise is important for our health. It's part of what helps to keep that nutrition going to our tissue.
And even if you can't, let's say your knee's really irritated and you can't work on the local tissues, go above and below. Work on the ones above and below. Because this is too irritated, I can't do much at my knee, so maybe I'll work on my hip. These tissues, I'll work on mobility from below, which will take some of the pressure off. My hip is moving better, ankle's moving better, I have better stability. Take some pressure off my knee, and then it allows you to start working on that knee too.
What about crossing your legs?
Nothing wrong with that.
So,
But isn't that hard on your hips and your knees? I
so
mean,
kind of
over
turn
a
your leg a
long,
little
yeah.
sideways.
Well,
and
not
over
if
a
you,
long
period of time.
not if you have good mobility.
Yeah.
If you have good mobility, I mean, technically, the cross-legged sitting is actually a very stable position. It's that football position, if you have good mobility and if you do that.
But are you talking,
Yeah.
but are you talking cross-legged sitting on the ground, or are you talking
Yeah,
cross-legged sitting
well, no,
on a chair?
even in relation to that, I mean, if you have good mobility, it's different. If you're able to maintain that alignment, it's different. But if I'm stiff, my hips are stiff, eventually you are going to get in a poor, awkward position with your spine. Yeah.
That's okay. Doesn't hurt the knee or put any pressure on the knee or.
I don't think so. Yeah.
I think part of what we're saying is, it's kind of like the equivalent of people saying, well, what kind of chair is best for me? Is that you can get hurt doing anything, but it's kind of knowing yourself. Because you can also maintain a better position. So if it's sort of knowing, if you know you've got really a lot of tightness through here, and then you're in this position and you slowly feel a lot of tension and you feel a lot of burning here, then it's being in tune with your body and listening to it and saying, okay, well, something's not that happy there. I think I'm going to move this over, or I'm going to switch.
This isn't stretching.
Come up through here. Yeah, this is stretching. Exactly. Sometimes, yeah, no, it's not actually sometimes. You sometimes are exactly. Just like that, it'll stretch. Okay. So let me go through the step down, step down and the triple extension, just to mention those as tests, but also kind of if we're progressing in exercise. So now I've gone to some weight bearing. What I might do, if I'm going to check the step down, do you want to come up here and do the step down?
See which one I'll do.
So what I'm going to have you do,
Okay,
we're
which
going
one?
to stand up here. Oops.
Which
Which leg would you like? Whichever leg you like. And you're going to put the other leg in front of you and then come down and touch your heel there. Step
That
down.
was lovely. I
That
can't
was
say
the
I'm
left
gonna
leg.
do so great. I will try with this one.
Whoa. And come up.
It's my ankles, I think.
Your ankles, yeah.
Yeah.
So what are we looking at with this?
We're looking at, I never in my life, even as a kid, could squat without falling back on my butt.
Oh, is that right?
So I think I
Is that
have
right?
inherently kind of very stiff ankles.
Uh-huh, right.
So that's about as
So
low
if
as I
she's
can get on
got-
either knee.
She's got to flex. Look how much you have to flex at your ankle to step down, right? That's one thing there.
Well, also the issue of how a knee is moving side to side.
Exactly, exactly, yeah. So we're looking at So she may have been fine standing on a single leg, but as soon as she comes down, if that knee starts to veer in, then she's losing that stability. It's also balance, right? I'm standing on one leg and I'm having to balance my whole body weight. And then it's strength. Does she have the strength in her quads, glutes, and
And
hamstrings
this
to
is the
lower
one,
herself down?
this is the surgical knee.
Uh-huh.
The way you adjust your heel.
Yeah.
What?
As you adjusted your heel, you stuck your foot out to the side to balance yourself.
Uh-huh.
So,
You
yeah,
have a harder
so
time with
I'm,
this one.
huh?
You have a harder time with this
Oh,
one.
yeah, sure, because there's a lot of scar tissue. This was immobilized for about 3 months. So it was very, So there's my,
Yeah. Yay, thank you. Gonna come on up. I'm gonna mention the triple extension because I have that in there. One thing that I look at sort of a test. So I'm gonna have you, it's about hard to see, go like this, bring one leg up. Like this. Uh-huh. And bring one leg up. Okay. So from this position, go ahead and lift your head up. What I'm looking at is triple extension is can she extend at her hip? Can you extend at that hip? Oops.
Oh, I just think the videotape is just because I
Oh, whoops. You stand on this side, sorry. So yes, let's try the other leg there. Can she, I'm looking at can she extend at her hip? Can she extend at her knee? And then how far she can flex back through here? And can she do that with this other leg coming forward? Because this is part of her stride, right? When she's got one leg coming forward. And now can you push up on your toes? And so when she does that and her butt sticks out, boom. Not a good thing there. So she's collapsing when she's running there. And then head's coming forward here. So even before I go up there, this position, part of this position too is, does she have core strength?
right.
So we're looking at it's kind of almost like a modified plank position there. So those are a few things I'm going to look at when in a runner, say when I'm looking at triple extension. And then that'll guide me towards maybe I'll have her do a plank and look at can she really hold it with her butt down or is her butt coming? Yes, we can go sit down.
The only thing I was going to say was, I mean, as Lisa was saying, think about the progression of things. So depending on how much your knee tolerates, whether you're trying to get the range of motion or strength. So going from that non-weight bearing position where you're unloading that joint, it's a load bearing joint. If it's not tolerating loading, you must pick something else. So go to non-weight bearing strengthening and mobility first, and then you progress to more weight bearing things. Okay, so you just keep that guideline. So the knee will tell you. If it doesn't like it, who was mentioning? Ruth, were you mentioning? Doing the exercises and then coming back and having a lot more pain?
Yeah.
So a little bit of soreness is different. But if the joint is irritated, there's more swelling, there's more pain, something is wrong. You know, the exercises that are not correct for you or for that time frame, you know, so you have to evaluate and you maybe have to back up a little bit.
Well, the knee just got all crunchy. And it was explained to me, you keep doing the exercises and the crunchiness will go away.
Sometimes no.
Anyway.
So I mean, and that's where the, you know, it's important not only with the exercise part, so that other components, which is, you know, doing more hands-on massage or joint mobilization, soft tissue stuff is very, very important also, which is often overlooked because it's like, here are the exercises, because it's easier. I mean, it's not easier, but easier for me to give you a few exercises and send you on your way than educating and really getting in there and figuring out the problem. Maybe you need hands-on mobilization of that ankle joint, and then I give you stuff to do at home to improve that mobility of that joint too, as well as that knee and whatever else. So this is where a lot, sorry, go ahead. Yeah.
There you go.
No. It's okay.
You're playing tennis and you're done and your knee's hurt. Are you doing ibuprofen and a bag of ice?
Oh,
I'm not Manu.
Like, right, that sounds like that's a double bag from what
Double
you've been
bag,
talking about
absolutely.
versus stretching.
Absolutely.
Yes.
Or you back off. I mean, why is the knee hurting, right? I mean, I know that part of it has to do with because we want to do what we want to do.
Yeah.
I mean, your joint has X amount of miles on it. I mean, you have to respect that, and everybody's joints are different. Some people can run marathons. I know I have friends who run, you know, I don't know how many marathons they run, and they can tolerate, they can handle it, just the way they're built to handle that stuff. Other people can't do it physiologically. Just the joint, and maybe, you know, besides their physiology and biomechanics, and there might be other factors, or there might be an old trauma to the joint in the past. they just can't tolerate that activity. So I might have to modify the activity. Maybe I don't play for 2 hours, I play for half an hour, and I do it 3 times a week instead of once a week. You have to adjust things.
Yeah.
But the ibuprofen and icing,
My husband won't use ibuprofen because he says it covers it up.
yeah, it's a good way to, I mean, your body's telling you something, so,
Yeah.
you know, I
Yeah.
wouldn't, yeah.
So we haven't talked about shoes very much and orthotics and such. But I noticed that it's almost to the minute of the 6 months that I have to change my running shoes. I start getting knee pain and I get a new pair of running shoes and then it seems fine again.
Oh, yeah.
Well,
It seems a little expensive though.
Somebody's your body is.
well, there are a couple of things with that, into that, you know, one is obviously if it helps you, you do, and you change your shoes. But, you know, recently there's a lot more research, you heard people talking about barefoot running and all those things, and obviously there's inherently something going on in the ability of your foot, either the mobility or the strength, the motor control that it does not handle, and it needs more support or better shoes periodically. So if you know, if you started working on walking barefoot, right, and I'm talking, you don't have to do this, but you increase the time progressively. You try to see how much does it tolerate, right, because you get to start using your foot muscles, you know, and then doing specific exercises and mobility things too. So I mean, there's a, and again, I have physical therapists, Shannon, for example, you know, who are all for getting orthotics and getting the shoes, and but I have other PTs who have said, for example, we were talking about the arthritic knees earlier, and Lisa was mentioning how you know, if let's say the medial aspect is wearing out or one side is wearing out, and then you put you say, well, my foot pronates, I have flat feet, let's get them an orthotic. Now I place more pressure on that inside part of the knee too. Then I start wearing out the inside part, and the knee starts to hurt on the inside. So it really depends. It's case by case basis.
Yeah.
So you know, you have to really assess and. Sorry.
Yeah, I would say in general, I mean, I do like orthotics, and I was going to mention that that's something for, if I was having knee pain on a daily basis, I'm probably going to not wear flats or flip-flops, but wear something that does give me more support, or check it out if it's something that gives me some more support. The orthotics that I like the best, the over-the-counter ones, are Super Feet. I have an example of those. I think they're great.
That's what I use.
They come in different colors, and not just because they're pretty, but for different uses. Some that are a little bit higher for like athletic shoes, some that are a little bit lower for shoes that are low profile. I think these are for like dressy shoes, that kind of
They
thing.
even have a short one for
Oh.
high heels.
Oh yeah, for high
They
heels.
actually work great if your arch is high in a regular shoe.
Okay.
They're just a
yes,
half.
Yes. And I have some in certain shoes that I wear. I don't know if you want to look at them. But at the same time, what Manu is saying is, I then went to a running course where that was taught by a woman who runs the Harvard running clinic or running lab, and she was someone who was a diehard make orthotics. She was a physical therapist and diehard make orthotics for everybody and put them in, evaluate whether they need shoes that are stability or mobility shoes. And she converted to barefoot running. And then part of what she does at the clinic is transition people to barefoot running. Now that being said, there are intense requirements in terms of the foot support. So actively using and training your foot intrinsic muscles, because the problem is we go around with good shoe support and you can actually get weaker. The more support you might give yourself, you can get weaker at those muscles. So there's a lot of foot exercises that you want to do before you're going to try something like that. So, but I think, like Manu said, it's a choice. I want to try to, I do believe in both sides that sometimes you need that external support, and if you're having a lot of pain and you know that if you wear supportive shoes it feels better, then, and you're going on vacation or going to the Giants game, I'm going to wear my sneakers. I'm not going to wear my nice, little pretty shoes there if I'm going to be up on my feet all day. But at the same time, I'm probably going to work on strengthening my feet and maintaining that strength in my calves and legs too. So, I think it's a little bit of both,
Yeah, I go back and forth.
Go back and forth, yeah.
I go do barefoot running and I do orthotic running.
Do you really? Ah.
Yeah, I'm just like,
Yeah.
philosophically.
Yeah, yeah.
Or-
So,
Well, should we get time?
Yeah, I know, I know, sorry, we've gone way over,
bit
that's
over
over
time.
time now.
We're not gonna
Everybody's got, everybody's
So,
got things to do.
I guess if you wanted to have a conclusion, or if you wanted to, if you guys were pretty much done, or?
Yeah.
Okay, well, you all, thank you, that was so great. I actually was a lot myself. And, a good job, and, you know,
The only thing I was going to say was, I mean, as Lisa was saying, think about the progression of things. So depending on how much your knee tolerates, whether you're trying to get the range of motion or strength. So going from that non-weight bearing position where you're unloading that joint, it's a load bearing joint. If it's not tolerating loading, you must pick something else. So go to non-weight bearing strengthening and mobility first, and then you progress to more weight bearing things. Okay, so you just keep that guideline. So the knee will tell you. If it doesn't like it, who was mentioning? Ruth, were you mentioning? Doing the exercises, then coming back and having a lot more pain?
Yeah.
So a little bit of soreness is different. But if the joint is irritated, there's more swelling, there's more pain, something is wrong. You know, the exercises that are not correct for you or for that time frame, you know, so you have to evaluate and you maybe have to back up a little bit.
Well, the knee just got all crunchy. And it was explained to me, you keep doing the exercises and the crunchiness will go away.
Sometimes no.
Anyway.
So I mean, and that's where the, you know, it's important not only with the exercise part, so that other components, which is, you know, doing more hands-on massage or joint mobilization, soft tissue stuff is very, very important also, which is often overlooked because it's like, here are the exercises, because it's easier. I mean, it's not easier, but easier for me to give you a few exercises and send you on your way than educating and really getting in there and figuring out the problem. Maybe you need hands-on mobilization of that ankle joint, and then I give you stuff to do at home to improve that mobility of that joint too, as well as that knee and whatever else. So this is where a lot, sorry, go ahead. Yeah.
There you go.
No. It's okay.
You're playing tennis and you're done and your knees hurt. Are you doing ibuprofen and a bag of ice?
Oh,
Is
bad.
that
Not Manu.
Like, right, that sounds like that's a double bag from what
Double
you've been
bag,
talking about
absolutely.
versus stretching.
Absolutely.
Yes.
Or you back off. I mean, why is the knee hurting, right? I mean, and I know that part of it has to do with because we want to do what we want to do.
Yeah.
I mean, your joint has X amount of miles on it. I mean, you have to respect that, and everybody's joints are different. Some people can run marathons. I know I have friends who run, you know, I don't know how many marathons they run, and they can tolerate, they can handle it. It's just the way they're built to handle that stuff. Other people can't do it physiologically. Just the joint, and maybe, you know, besides their physiology and biomechanics, and there might be other factors, or there might be an old trauma to the joint in the past. They just can't tolerate that activity. So I might have to modify the activity. Maybe I don't play for 2 hours, I play for half an hour. I might do it 3 times a week instead of once a week. You have to adjust things.
Yeah.
But the ibuprofen and icing,
My husband won't use ibuprofen because he says it covers it up.
yeah, it's a good way to, I mean, your body's telling you something, so,
Yeah.
you know, I wouldn't, yeah.
So we haven't talked about shoes very much and orthotics and such. But I noticed that it's almost to the minute of the 6 months that I have to change my running shoes. I start getting knee pain and I get a new pair of running shoes and then it seems fine again.
Oh, yeah.
Well,
It seems really expensive though.
Everybody is your body is.
yeah, exactly. Well, there are a couple of things with that. Into that, you know, one is obviously if it helps you, you do, and you change your shoes. But you know, recently there's a lot more research. You heard people talking about barefoot running and all those things, and obviously there's inherently something going on in the ability of your foot, either the mobility or the strength, the motor control that it does not handle, and it needs more support or better shoes periodically. So if you know, if you started working on walking barefoot, right, and I'm talking, you don't have to do this, but you increase the time progressively. You try to see how much does it tolerate, right? Because you get to start using your foot muscles, you know, and then doing specific exercises and mobility things too. So I mean, there's and again, I have physical therapists, Shannon, for example, you know, who are who are all for getting orthotics and getting the shoes. And but I have other PTs who have said, for example, we were talking about the arthritic knees earlier, and Lisa was mentioning how if let's say the medial aspect is wearing out or one side is wearing out, and then you say, well, my foot pronates, I have flat feet, let's get them an orthotic. Now I place more pressure on that inside part of the knee too. Then I start wearing out the inside part, and the knee starts to hurt on the inside. So it really depends. It's case by case basis.
Yeah.
So you have to really assess and start.
Yeah, I would say in general, I mean, I do like orthotics, and I was gonna mention that that's something for, if I was having knee pain on a daily basis, I'm probably gonna not wear flats or flip-flops, but wear something that does give me more support, or check it out if it's something that gives me some more support. The orthotics that I like the best, the over-the-counter ones, are Super Feet. I have an example of those. I think they're great.
That's what I use.
They come in different colors, and not just because they're pretty, but for different uses. Some that are a little bit higher for like athletic shoes, some that are a little bit lower for shoes that are low profile. I think these are for like dressy shoes, that kind of
They
thing.
even have a short one for high
Oh.
heels.